So, Mike, in terms of understanding risk in high value care, using whole person risk to impact population health strategies and outcomes, what's changed in the marketplace that would have medical groups or individual clinicians be more interested in leaning into this?
Yeah, with the new Make Care Primary and also the ACO Flex programs that Medicare is putting out, uh, it's now providing an opportunity to get paid on a PMPM basis, which really aligns payment better with improving outcomes and taking on risk. This is really true for primary care groups, especially, but also health systems that have primary care groups that are part of their system. If they want to align the payment around the outcomes that they're seeking in lowering costs and improving quality, those two payment programs from CMS are really helping provide that opportunity. But in order to be successful in that, you really need to have a population health strategy that is based on a high value advanced primary care model. So the question is, how is your organization developing the data analytics and the primary care practice model to achieve a robust population health strategy?
I know you and I have been a part of the patient-centered medical home for decades now. It feels like at least 15 years for me. And one of the things that we hated was it was just adding a bunch of administrative work. It didn't feel like it made any sense in the way that we saw patients and what we did and how we cared for adding years to the life and life to the years, which is our mission here at Converging Health. How does what we're doing different from the patient-centered medical home model that so many people got very frustrated with?
Yeah, the PCMH model really was challenged by the fact there was no real payment reform attached to it. And so it didn't allow people to be properly incentivized for getting the outcomes improving that they were trying to do in their practice. And the other thing is, I think we've really advanced our thinking around what advanced primary care is. The different components of it. In the past, none of those experiments really had a population health strategy attached to it, and now we have data analytics that can really inform how we can look at our high risk populations and take on that risk really effectively.
Yeah, I remember being a patient-centered medical home, and I helped about 17 groups become patient-centered medical homes. And it was just an absolute paperwork nightmare. And then it didn't change the way we cared for patients. What I hear you saying is with the advanced analytics that we're able to bring, you actually design the day-to-day activities of the entire care team around incorporating and using risk modeling, and then all of the stuff we did the paperwork around, which made sense, it was a great idea, but was disconnected and didn't fit into our workflow, now just becomes part of the normal work. So we're actually practicing medicine in an easier, better way, and we accomplish the goals of what we wanted to with the patient-centered medical home. But the key for me is the data analytics and the workflow redesign.
Yeah, so Scott, from your perspective, tell me about how we should understand risk.
So we have to answer three questions. I'm talking about you and I, primary care clinicians primarily, but it's really true for all clinicians. So the risk model is the absolute risk. What does this person have? What do we need to overcome? The clinical quality risk. How well are they being cared for and following the pathways of care for major conditions? And the flare risk, how well are they engaging in their care? If you have a clear picture of that, you've got a beautiful whole person risk 360 model that you can hand off to everybody from the receptionists and telephone operators to do proactive outreach and to get people ready, to the clinician to do the work that they have to do and decrease the work of each member on the team, but increase the effectiveness of the team model.
Yeah, so the question we're going to be asking a lot of systems that we want to work with are, what is your risk tool and how well does it actually bring out those components? And I think that's one of the problems that we see is that a lot of people don't have those type of risk tools available to them.
When we think about transformation, we think about five things. The first thing is how are the people on the teams thinking about their situation and how it can get better? And I think that's a step that most transformation efforts overlook. We have a book called The Art of Medical Leadership and a program called The Art of Medical Leadership for every person on the team. The second thing is the data. And the data's got to be intuitive, at your fingertips, and informing the right action. And then the third thing, though, is actually changing the workflows of the clinic to utilize this mindset and tools. How do we do that? Or what are your thoughts about how you use the mindset technology and the information technology to actually change the process.
Yeah, so this is where advanced primary care comes in because the definition of advanced primary care is really built on a foundation of data analytics to support a proactive population health strategy. So and this is where a lot of systems fall short is that a lot of people have tons of data about their patients. They may have risk tools within their EMR, but most of the time they're incomplete and they don't really have an implementation plan of how to use the data to actually transform the care they're delivering. So the advanced primary care model creates new workflows and focus on patient engagement and trust, which is much more effective in getting them to change behaviors, which is then leads to lower risk across your population. So that with the advanced primary care training that we do, we help clinicians and their teams learn a different way of doing what we call a high value visit, which is a targeted visit that helps them really meet the needs of their patient more effectively. And they do that as a team, so it's not all just dumped onto the clinician to do the work. And with this targeted outreach for high risk members, which is based on the risk tool and the team based care, we've seen dramatic lowering of cost and improvement of outcomes within the populations we've been able to work with.
It's fantastic. Um, we talk about the quadruple aim or maybe even the quintuple aim in instances, but in the quadruple aim, what do you see from changing workflows, utilizing the information that is just in time and having the right mindset?
Yeah. So what we've seen in our surveys, we actually survey, obviously we get patient surveys back and we've seen that patients have felt like they're much more connected to the team based on these high value visits. The team itself also reports back a very significant increase in morale within the team that they feel like they're doing really high value work. And everybody understands much more clearly their role, but also the goal of what they're trying to do in taking care of their patients. And so, in the teams that we've worked with, we've seen that positive feedback from the care transformation piece. And so you get this improved patient engagement, improved team satisfaction, coupled with lowering total cost of care and increasing the value of that care. So all of those things are all part of the quadruple aim. Yeah. So Scott, how does converging health actually meet these needs, and what kind of solutions do they bring?
Well, converging health is very unique because we not only have all the information and analytics that we bring to bear, and we can integrate those in the electronic medical record, or we can have it lay over the medical record so it can go. We have one group that we work with now of 158 clinicians. We can put the information that they need to manage this in front of their EMR, so it's very easy for them is another option. But we are able to take the information for people as they get out of the overwhelm of the fee-for-service model, help them develop these new pathways of care inside the office and around the office, and then do vertical integration with the specialist. So we are an informatics company, and we are a consulting company that actually helps groups, teaches them how to fish, gives them the tools to fish well, and then sets them on their way to be successful over time.
And we're excited to see these new models coming out from CMS and from other payers that are going to be driving, basically the aligned incentives around payment. And with our training expertise and our informatics expertise that we have, we can actually really support that transformation that needs to happen. And it is almost a multi-year process to get that transformation done. So we encourage systems to think about bringing us in early as they're moving into taking risk, and then implementing this advanced primary care model across your system is driven by data that helps you have a robust population health strategy, will lower your total cost of care, improve outcomes, and provide financial success and health to your health system, your practice, or your ACO.
If I knew everything that I knew my senior year of college, my first day I walked into college, my college experience would have been much better. And I probably would have had a lot more fun, and I would have done a lot better. What we've done here is this is the fifth time you and I have gone through working with a group of clinicians, physicians, and nurse practitioners or physician's assistants, brought technology to bear, change the way they think about what they do, and watch them become more profitable and enjoy the process across the entire team. So us being able to start from a place of understanding what it looks like when it's done would be like knowing everything that you learned during college on the first day of college. And that's really, I think, our value is we can bring that to bear quickly. And I say quickly, meaning over 18 months to get the initial system up functioning and really kicking rear end. And then over the next 18 months, build around the clinic services or fine tune around the clinic services, as well as the specialist integration and pathways of care.